Okay. All right. Good afternoon and welcome to the Department of Medicine Grand Rounds. I'm not certain if you see me or not, but that's not important. I'm here to present our speaker today, Dr. Manuel Herrera. Dr. Herrera is an assistant professor of neurology in the Department of Medicine, Division of Neurology, and staff epileptologist in our epilepsy program at Hamilton Health Sciences. Dr. Herrera completed, following his residency in Peru, completed a 2 years fellowship training in epilepsy and electroencephalography at University of Western Ontario in London Health Sciences Center of Epilepsy Program. He practiced for at least a year in Peru at the epilepsy department of the National Institute of Neurological Sciences. And then we were lucky to recruit him here at McMaster. Dr. Herrera's primary clinical and research interests are in the treatment of medically resistant focal epilepsy, presurgical assessment, palliative treatment, neuromodulation, with specific emphasis on deep brain stimulation. It's not a surprise that Dr. Herrera will talk to us today about the surgical approach to the medically resistant focal epilepsy. Without further ado, Dr. Herrera, please go ahead.
Good afternoon. Thank you for having me here for these medical grand rounds. I'm going to share some information about the presurgical assessment that we used to perform in the epilepsy unit centers, especially in our unit here at Hamilton Health Science Center. So I don't have conflict of interest to state. The objectives for this talk are going to be to review the updated definition of epilepsy and medically resistant epilepsies. We're going to familiarize with the surgical approach in these drug-resistant epileptic patients. And an important part of the talk is going to be to emphasize the role of the semiology in epilepsy for this presurgical assessment. We're going to start with a brief definition and describing the old classification that is still being used to this day, although we have a recent classification that is in the process to be published by the ELI, that is the International League Against Epilepsy. We're going to review briefly the diagnostic algorithm for when we are facing a patient with the first seizure, and then our talk is going to be focusing the medical in those cases with drug-resistant epilepsy and how to approach, especially the first phase of the study for an eventual presurgical plan. So as you probably are aware, since 2014, the definition of epilepsy was modified. Actually, the concept of a seizure was coming before from 2005, describing that an epileptic seizure is a transient occurrence of signs due to an abnormal and excessive and synchronic discharge in one specific network in the brain. And then the epilepsy was defined as an enduring predisposition to have seizures in the future. But how can we know, or how can we define or outline this predisposition to have seizures? And that's why these criteria were established in 2014 to have a better communication between different centers for the diagnostic of this problem or this disorder. So you have to, for you to label a patient as having this epileptic disorder, you have to have at least 2 unprovoked seizures or reflex seizures occurring more than 24 hours apart. This reflect concept means that some stimuli that could be in the environment may trigger or they may decrease the threshold of the brain to have seizures, and that is why this kind of a stimulation is not considered like a provoked seizure, which is a different scenario. For example, a patient having a stroke or a patient having meningitis or encephalitis. Those patients may have seizures because of the acute brain injury, and this is what we call an acute symptomatic seizure or provoked seizure. So for the definition of epilepsy, we have to have in mind that those are unprovoked or reflex seizures happening more than 24 hours apart. Another criteria is to have one of these seizures plus the risk of having a second seizure that is similar to those patients who have already had to unprovoked seizure. And that kind of risk was estimated around 60% in those patients who have, for example, after a single seizure, abnormal results in the EEG or the MRI that are fitting with the semiology of the first seizure that we were witness for the patient. And then a third criteria is to have a diagnosis of an epileptic syndrome since the very beginning of the consultation, which means having an electrographic and clinical correlation for one specific epileptic syndrome that we're gonna talk about for just some of them. So these are just examples of patients, for example, presenting with this 25-year-old woman presenting with 2 seizures that are considered unprovoked and 1 year apart. So in this case, the patient will fit the criteria to be considered epileptic, and we should treat this disorder according to the clinical signs and the spectrum of the epilepsy. In this other example, we have a patient, a 60-year-old gentleman having a stroke 8 weeks ago and presenting with an unprovoked seizure. So in that case, this patient probably will fit the criteria because he has a lesion that will put him in a predisposition to develop more seizures in the future. So this patient will fit the second criteria to be considered epileptic. And then the last example would be a 6-year-old boy who had 3 seizures, or who had 2 seizures 3 days apart, and these seizures were triggered by visual stimulation when he was playing video games. So again, in further investigations, the EEG showed some abnormal paroxysmal response that are some specific interictal electrographic features that will allow us to do the diagnostic of an epileptic syndrome. So this will be in keeping with the third criteria, and this patient will be considered epileptic as well. So once we are dealing with a patient either in the emergency department or in the outpatient clinic complaining about the first seizure, the first step is going to determine if this first paroxysmal event is a seizure or not. It seems to be very basic, but it's a key because there are several conditions that can mimic a seizure, like you can see here in the list. Then another differential diagnosis like syncope, stroke, migraines, etc. So it's not the purpose of the talk to go in detail through this process, but I would like to show you the key aspects of what you have to have in mind in terms of clinical information to do the diagnosis based on clinical grounds. So when we're facing an epileptic seizure, it's important to identify for those patients who have a focal seizure, this period that is called an aura, that are just subjective manifestation of the patient, like a fear sensation without explanation, like a deja vu feeling, like a roller coaster feeling, like a visual perception of some lights, some flashing lights in one specific visual field. Different symptoms that are just subjective last a few seconds before the patient starts showing the objective signs that we're going to see, or we are going to categorize as the ictal phase. For example, in a temporal lobe seizure, the patient may complain about an aura of epigastric rising sensation and then progress into a focal and aware seizure, which means that the patient is going to be unaware of what's happening around. It's going to be probably staring off, displaying some automatisms, oral or manual automatisms, and that is the ictal phase. Once the discharge in the brain is over, then the patient will have like this posictal stage that it's also important to figure out, because during this stage, the patient may have some confused behavior. Some patients complain about sleepwalking if the seizure happens overnight. So patients can have an unusual and inappropriate behavior between quotation marks. Some patients may complain about unilateral posictal headache. So we can find signs that are important to outline during the interview. If the patient doesn't go into the posictal stage and continue with the ictal signs, then we have the risk the patient has the risk to go into a status epilepticus. And the key part of this semiology is that the aura and the ictal phase should last a few seconds or minutes. If this is prolonged, then we have to have in mind the other differential diagnosis, for example, panic attacks, psychogenic non-epileptic events, that they usually last 15, 20, 30 minutes. And in the case of panic attacks or psychogenic events, they are triggered by stressful situations, for example. I would like to show this clinical case and show you the video about the features, because this lady was, for example, considered a patient with a diagnosis of psychogenic non-epileptic events. And the history, or this 22-year-old lady complained with a 3-year history of episodes of fear associated with vigorous shakiness, like pelvic thrusting, pedaling movements, rolling over the bed, and punching things around. So she presented to the clinic complaining about bruises, nose fracture, black eye because of these concussions that she was having during this event. It's remarkable that those events were exclusively at night, out of the sleep. The patient was most of the time unaware about the feeling just at the beginning, and he was able sometimes to feel the fear just at the beginning of the episode. Then she will be unaware about what's happening around. Most of the information was provided by third persons, like witness, family, and partner. So this is the video I will show you. Please let me know if you have any trouble to see this. You can see the patient is sleeping, and out of the blue, the seizure lasted less than 30 seconds. And then in the procedural moment, she was kind of confused, not knowing where she was. The nurse was able to provide some support, explain her what happened. So analyzing this case, this patient may or may not have an aura. In this case, it seems that she just woke up probably having this feeling. We don't have a clear explanation. She was not able to recall for this specific event, but it seems that a few seconds before, maybe 1 or 2 seconds before the hyperkinetic behavior, she just opened the eyes. She had an expression of fear, and then she progressed into this hyperkinetic component lasting less than 30 seconds. So following this kind of pattern. And then in the postictal, for a few seconds, she was confused. So based on clinical grounds, of course, it's different to comment this after seeing the video. And that's why the patients are admitted most of the time to the epilepsy unit for differential diagnosis purpose. But in this case, based on the clinical history, we should suspect a focal frontal epilepsy because of the pattern. Brief episodes happening out of the sleep, lasting a few seconds, confusion associated, and several injuries associated with these episodes. So this was finally a case of a focal frontal epilepsy coming from the orbitofrontal region, which is uncommon. It's not very commonly seen. So as I mentioned, the first approach is to figure out if the paroxysmal event is a seizure or not. Then we have to figure out if this is unprovoked or this is an acute symptomatic seizure in the context of an acute brain injury. Then, as a third step, we have to investigate if that seizure was actually the first one, or maybe the patient was having previous focal seizures that were not easy for the patient to describe since the very first time, or the patient probably didn't pay too much attention to these episodes, because it happens most of the time. We are dealing with patients complaining with the first seizure that was a tonic-clonic one, and during the clinic assessment, we figure out that he was having a history of 2 years of deja vu sensation or focal unaware episodes. So this is part of the diagnostic process, and that will allow us to address the problem in the correct way and give the treatment that is necessary for these patients. So in 2017, there was an operational classification for the seizures. It's not the purpose of the talk, but we just briefly review that focal seizures are those one with this kind of abnormal and excessive and synchronic discharge occurring in one specific spot on the brain. And depending what is the spot triggering this activity, we will have different symptoms. We can classify this as focal aware or focal impaired awareness seizure, and if there are motor components with motor onset or non-motor onset. For generalized seizure, those that usually don't have an aura, if there is a questionable aura, it's just a very non-specific sensation, less than 1 second, that doesn't allow the patient to get any safety position, for example. But focal seizures and generalized seizures mainly, when we don't have enough information to classify these episodes in the first clinic, we have this category for unknown onset. This is the new version that is starting and circulating this year, was published in April. So far, we have some polemic discussions because the level of consciousness here is not distinguished between the real level of consciousness that is associated with postural tones or the level of awareness that is kind of just being unaware what's happening around, which is an important part of the semiology in the seizures. So once we have this certainty that the seizures or the episodes that we're dealing with are seizures, then we classify it as focal or generalized, and then if the patient meets the criteria for epilepsy, this would be a patient with focal epilepsy or generalized epilepsy or combined generalized and focal, like, for example, those cases with patients with Lennox-Gastaut syndrome, for example, that will have different type of seizures, focal and generalized. And then the most important part of our talk is going to be this item that is the drug-resistant epilepsy or medically resistant focal epilepsy. I'm going to center my discussion in the focal epilepsies that are medically resistant. So the definition is, for those type of cases, are drug-resistant epilepsy are those one who fail to an adequate trial to tolerate an appropriate or appropriately chosen anti-seizure medications, which means that appropriate intervention is that one that when I have the type of epilepsy, I prescribe the medication that was proved to work for this specific type. For example, it is known that the ethosuximide, that is a good medication for absent seizure and absent epilepsy, it's not going to work for focal epilepsies. So if I prescribe this medication for a focal epilepsy, I'm not doing an appropriate intervention. And then we have the second consideration is that once the medication is chosen appropriately, we have to titrate up the dose to be sufficient to control the seizures. But if the patient, for example, develops side effects and we're not able to achieve this target dose, then this medication was not used. So the definition of a failure to two anti-seizure medication, either alone or in combination, should be done after having these considerations in our practice: appropriately chosen and adequately used. It is known that the focal drug-resistant epilepsy are around 35% of the cases. So we will have that our patients with epilepsy will have a good response in 50% of the cases. And then adding a second anti-seizure drug, we will have an extra 11% of patients. But going further with 3, 4, 5 anti-seizure medications so far have been proved that there is no extra help that we will get in terms of anti-seizure effect, and we're going to expose the patient to the side effects of the drugs and the combination of them. So for that population that is called medically resistant or drug-resistant epileptic patients, what can we do for them? So what we offer for those cases that are susceptible to, we offer a surgical approach to try a surgical epileptic a surgical resection of the epileptogenic zone to provide seizure freedom to these patients. That's the object. That's the goal. And so far, the epilepsy surgery approach It's the gold standard based on these studies. So in 2001, there was a randomized control trial that was done by the Canadian group led by Dr. Whip that proved that the surgical approach for patients with medically resistant temporal focal epilepsy, it's the best option. So in this study, 80 patients were divided in two groups, 40 and 40. One group underwent the surgical management with an anterior temporal lobectomy, and the other group continue with the medical treatment. So at the end of the year, it was found that 58% of patients that underwent the surgery were seizure-free, compared to the 8% of patients who continue in the medical treatment. The difference was statistically significant, and since then, several studies were performed and collected the same data. A systematic review that was performed by Dr. T. Centeno years ago also showed that in the long term, for those patients who have temporal lobe epilepsy, the surgery still provide a very good outcome in a long term, more than 5 years. So more than 60% of patients, actually 66 was considered or was estimated, continue to be seizure-free after a temporal lobectomy when they have an accurate study. And that's why we're going to review briefly the presurgical assessment. So the presurgical assessment for these drug-resistant epileptic patients has two phases. Phase 1, that is not invasive, and phase 2, that implies invasive studies like deep electrodes and intracranial grid recordings at the moment of the surgery. So for this presurgical assessment, we need to get information from different sources. All of them are very important, and the semiology plays a very important role here. Based on the semiology and focal features in a patient with epilepsy, we can determine what we call symptomatogenic zone. When we do the electrophysiological studies, when we got the interictal activity like just spikes, polyspike, spike and wave, we can determine with what we call this irritative zone. If we are able to capture a seizure during the epilepsy unit admission, we are going to get the seizure onset zone. If we get the MRI probably will show a lesion or not. If so, then we have a lesional zone. After the investigation in the epilepsy unit, that is an inpatient unit, then we are going to get, or the patient is going to undergo a neuropsychological assessment to figure out what is the area of functional deficit, and that is what we call functional deficit zone. I'm going to explain this with examples because what we need to do, or what we need to get for patients that are going to be good candidates for surgery, is that those areas that were mentioned here, they match and they try to point the same area. When we have that, we have higher chances to remove the epileptogenic zone with the surgery. The epileptogenic zone is the area able to synchronize the epileptic activity, and once it is removed, the patient is free of seizure. Because of that definition, this is a retrospective definition, and we just know that we were successful in resecting this epileptogenic zone in the evolution post-surgery. That is why we need to do all this investigation and try to figure out if those zones are matching so we can resect the epileptogenic zone. For example, within the focal epilepsies, the most common one it's the temporal lobe epilepsy cases. So this is a case of a patient with a temporal lobe seizure, medically resistant, that will undergo a surgical assessment. So just for you to have this clinical information, this patient is a 28-year-old man with a history of febrile seizure when he was 1 or 2. Then he didn't have any additional seizures. But then at the age of 15, he started to develop some episodes characterized by stomach discomfort that he described like a butterfly feeling associated with a strong sensation or feeling that he's living similar or familiar situation that he will describe as deja vu episodes. So we're having here this aura that is very typical for limbic onset. And we know that the structures that most of the time are involved in the seizures, like in this type, are the mesial temporal structures, like the amygdala, the hippocampus. So this is our first thought based on the semiology. Then the patient progressed after feeling the aura. Later on in his life, he progressed to having these blind staring episodes. He was told that he's staring off, and he may display some oral automatisms like chewing movements for at least 3 minutes. And then what he just realized is that he missed a gap of time. So the seizures complete the semiology of the pattern for a temporal lobe epilepsy with the aura, the ictal signs, that in this case is the focal and aware seizure with oral automatisms. And then at the age of 25, he had the first tonic-clonic seizure. And that's why he was looking for medical assessment after a night of drinking, after a party night, drinking alcohol, having a sleep deprivation, which are known to be factors that trigger seizures. At the moment of the admission, the patient was having 5 focal seizures per week. So these auras with progression to the staring off seizures. So this is the video of a seizure that we captured when the patient was admitted in the epilepsy unit. So the patient is sleeping and started showing some oral automatisms that you will see here. As you can see, he started to have some chewing movements. And then under the bed sheets, under the blanket, he will have some right hand manual automatisms. As you can see right now, he's having purposeless movements with the right hand. Then the nurse realizes, press the alarm button for the technician to know that the patient is having a clinical event. The patient is unresponsive. This seizure lasted almost 3 minutes. I'm going to jump to the 1 minute further. The patient continued unresponsive. This is still doing some automatisms, and you will notice that there he will progress to what we call a bilateral tonic-clonic seizure. And the physiopathological correlation is the spreading from the epileptic discharge to both hemispheres. You can see that he is having a head deviation to the right side that is forced, which is one of the important features that we try to figure out in terms of semiology, because that sign it's contralateral to the epileptogenic zone. So analyzing this case, for example, the job of our residents having the epilepsy block rotation, it's to figure out based on the semiology where could be the symptomatogenic zone. So in this case, we saw that the patient was sleeping, out of the blue started having some oral automatisms and right hand automatisms. It is known that when the patient in temporal lobe epileptic seizures, the patient displays some automatisms that are unilateral. Those automatisms used to be ipsilateral to the epileptic focus. So he was displaying some right hand automatisms plus the oral automatisms, the impaired awareness suggesting temporal lobe. And then we have the lateral eye sign, like the ipsilateral hand automatism. We can say, okay, maybe this is coming from the right temporal structures based on the clinical history and the semiology that the patient described, that their typical or his typical episodes were those auras with a strong butterfly sensation, like an epigastric rising sensation or the deja vu feeling. They suggest a limbic onset, likely the mesial temporal structures, amygdala or hippocampus. So probably this seizure is coming from the right mesial temporal lobe. Then later on, late on the seizure, the patient had a progression to a bilateral tonic-clonic, and we noticed that he was having a forced deviation to the left, which is a contralateral sign, also suggesting the right hemisphere involved here. So that's why in our analysis, previous to capture the seizures, we can say, okay, this is a right mesial temporal lobe epilepsy. The patient is admitted to the epilepsy unit. Maybe the first day of recording, we're not able to get any seizure because we're in the process of tapering down the medication, the anti-seizure drugs, but we find that the patient is having, or is showing, the recording is showing some spikes in these electrodes, F8 and T4, that are localized, that the localization of these electrodes are here on the surface, matching with the temporal region. So this is an expected finding for this patient. Then when we capture a seizure, we found that the seizure was arising from these electrodes as well, F8, F4, and some spreading to T6. So we have that the seizure onset zone is also pointing to the right temporal region. The patient, of course, underwent an MRI, and the MRI showed a right mesial temporal sclerosis. So we have the lesional zone fitting with the right mesial temporal area. After the admission, the patient underwent the neuropsychological assessment, and he was found to have some visual memory dysfunction that suggests the non-dominant temporal lobe dysfunction, pointing to the right in this case, because also in the neuropsychological assessment, the dominance is assessed with some test, like the dichotic test. So it was found that this patient has a left dominant hemisphere. So in the other parts of the neuropsychological assessment, he was found to have this visual memory dysfunction compatible with a non-dominant temporal lobe dysfunction. So in this case, the right temporal. So we have everything matching, suggesting the right temporal lobe is the responsible of these seizures. So the patient is a good candidate, and we have higher chances to resect the epileptogenic zone because it's likely involved, or it's likely present within the right temporal lobe, especially in the mesial temporal part. So the patient can undergo to a right anterior temporal lobectomy. Just in a specific case, we try to do amygdala hypocampectomies when there is a small lesion, maybe a cortical dysplasia that is well identified, but most of the time it's a temporal lobectomy. We can go from the temporal pole to the posterior margin around 4 centimeters if we're like 4 or 4.5 centimeters if is the dominant hemisphere involved, or up to 6 centimeters if it's the non-dominant temporal lobe. Then this is a temporal case, which is the most common and the most simple, let's say, in terms of investigations. But what happens if we have an extratemporal epilepsy, like the case that I'm going to share with you briefly? So we have this gentleman, or this young male, 18-year-old, complaining about nocturnal events over the last couple of years. Those episodes are characterized by a sudden awakening, extension of forelimbs, most of the time more notice in the left side, lasting a few seconds. Then he's confused for additional few seconds. This is happening 2 or 5 times per night. The 3 months leading up to the epilepsy unit admission. And he has tried more than 3 anti-seizure drugs, so it means that this patient is a case of drug-resistant epilepsy. So I will show you the video of one of the seizures that we were able to capture in the epilepsy unit. When the seizure is gone, the patient tried to leave the bed. He was contained by the nurse. He's in the positional moment right now, confused. And he quickly go back to his baseline. So let's go back to the very first seconds of the seizure. So the patient woke up. I just paused the video, and he seems to have an asymmetric dystonic posture. He has a contracture of both upper limbs, but it seems to be more prominent in the left side at the very beginning. As you can see here, he's bending forward. And an important data that he was also complaining about is that he woke up the next day with scratches on his face. And this probably was because of the tonic contraction of the left hand that is approaching more to his face, as you can see here. So the semiology in this patient suggests that there is an asymmetric dystonic posture, so prominent motor features. The seizures are sleep-related, so this highly likely suggests a focal onset within the frontal lobe. Based on this semiology, it's highly likely arising from the supplementary motor area, but we don't know if it's right or left based just on the clinical information. If we consider that the left side has a more prominent contraction, maybe it's the contralateral hemisphere, the one triggering the epileptic discharge. So this is the analysis that we do in the epilepsy unit. And then based on the semiology, we figure out, okay, maybe it's the supplementary motor area, right versus left, probably the right. And then we start the recording and we start seeing these spikes over the right frontocental region. And when we captured the seizure, because of the movement artifact, we didn't have a clear lateralization. So at the beginning, less than 1 second, we were able to see the onset of a seizure in the bilateral frontal lids, and then it's obscured by the artifact. That's a common thing that may happen in the scalp EEG recording. Then we got an MRI, or the patient came to the unit with an MRI that was reported as normal. And when he underwent the neuropsychological assessment, he was found to have some executive dysfunction that didn't allow us to lateralize to one specific frontal lobe, could be right or left. So we decided to repeat the MRI and to get an ictal SPECT. That is an additional test, not commonly done, but consists in the injection of a special contrast based on radioactive technetium that is going to go through the blood and it's going to reflect the hyperperfusion area that is suspected to happen just at the very onset of a seizure. So that's why it's important to get this test done within the first 30 or 20 seconds of the seizure. And in order to complete that task, a nurse was assigned to that patient. The nurse was next to the bed of the patient. The patient was known to have these seizures during the sleep time. So what we did is to do a sleep deprivation for the patient, and the patient was sleeping during the day. And when he was sleeping during the day, he started having this seizure. The nurse put the injection immediately within 10 seconds, and I will show you our results here. But first, let's go with the MRI. So when we review the MRI, we noticed that there was some, I will change my pointer. We noticed that there was some thickening cortex here in the mesial right frontal lobe that were noticed with some blurriness and lack of differentiation between the cortical and subcortical region was asymmetric. So we were suspecting in a cortical dysplasia that was not reported in the first MRI. This was a new MRI, and then we get the ictal SPECT, and after the processing software, we found that this was the area of hyperperfusion, matching with the area that is suspected to have the cortical dysplasia. So this patient underwent surgery because this investigation allowed us to be confident enough to resect that area that is suspected to be the epileptogenic zone. And the patient is doing well so far, 1.5 years of follow-up so far, so probably he's going to do okay for the next year. And then when we have patients, when we're not able to find a lesion in the MRI most of the time, that are extratemporal most of the time, we need to do a phase 2 of investigation that implies the placement of deep electrodes and stereo EEG recording. So the patient will go to a first surgery. The electrodes are going to be implanted with a previous plan, of course, based on the phase 1 investigations. And then the patient will go to the epilepsy unit with the deep electrodes implanted, and we're going to get the seizures that will mark the seizure onset zone that highly likely will represent the epileptogenic region. That is the phase 2 with deep electrodes, and we have another situations with we will go to the surgery resection. For example, the patient that we were talking about in the previous case, we can place a grid during the surgery to outline the area that is going to be resected, because sometimes it's not easily to know what is the extension of the cortical dysplasia, for example. And we may have a grid during the surgical procedure to figure out what is the epileptogenic zone and remove it during the surgical process. For those patients, just the last part of my talk is that for those patients who after the investigations, they turn to be not good candidates for surgery because maybe they have more than one epileptic focus, or because the single epileptic focus was in an eloquent area like the language or the motor function or visual area, primary areas, then those patients may be susceptible to get some palliative treatment like the neurostimulation. We have the vagal nerve stimulator that has different modalities. The normal modality implies that this device is going to send outputs of current every 5 minutes for 30 seconds to abort the seizure. If the patient is having an aura, this magnet, which is like a contour, like a watch, the patient is going to be able to swap the magnet and send an extra electrical and a stronger discharge to abort the seizure when the patient is having the aura. So this is how works the VNS. That is not the purpose of the talk. We have other devices like the DBS, deep brain stimulator, that goes to different deep nuclei, like for example the anterior nucleus of the thalamus. Or lately we have the RNS, that is a more advanced device that is going to be under the skull, and this device will have 2 electrodes that are going to go to 2 epileptogenic zones. The advantage of this device is that when this device is not firing, an electrical discharge to abort a seizure is sensing the electrical activity. So we have prolonged recordings of that brain. And when the seizure is coming, the device is able to notice that and send an electrical impulse to abort the seizure. So this is the information that I want to share with you today. I don't know if there is any question or any comment that I would be happy to talk about.
Thank you, Dr. Herrera, for this outstanding and fascinating review. Things that we don't encounter a lot. Actually, my own experience had a patient with a deep brain stimulator. We all had to learn how. He taught us how to use the watch, on his wrist to activate it when he has a seizure. So I can understand that this is very useful. If you have a question, please either raise your hand to allow you to come in person and share your question, or you can write it in the Q&A. And have a question here or a comment from Dr. Sheikh Youssef. Thank you, Manuel. A very interesting topic. Could you comment on the use of wearable in diagnosing seizure? Thanks. So wearables to diagnose seizure.
Sorry, could you please say again about the question was?
Could you comment on the use of wearables? I'm assuming about personal wearable devices in diagnosing seizure.
I'm not aware about those wearable devices. Could you please elaborate that more? Maybe I have with other names, and I can let you know.
Amir, if you would like to come in and ask your question in person or expand on the question, would be useful. Until we get Dr. Sheikh Youssef doing that, I was wondering, Manuel, we have been working over the years in Hamilton Health Sciences to get to a surgical program, and the recruitments like yourself, is getting us closer to that. Can you tell us, how far in this work, how much of this work usually is done within Hamilton Health Sciences or within Hamilton, and how much of it is done currently at other centers that we collaborate with?
So we have epileptic centers here in Ontario. For example, we have in London, that is the center that I was training. A couple of years ago. So we have that. We have in Toronto. We have in Montreal. In Ontario, I'm not aware about more than 3. The other important ones are in Alberta, BC, of course. So this is a third center that where we are supposed to get patients just with drug-resistant epilepsy to complete this presurgical assessment. Of course, we have the epilepsy clinic for patients who are just having a first seizure. But so far, the program I would say that there is at least 4 centers in Ontario to perform presurgical assessment. Our case in Hamilton right now is that we're doing the phase 1 investigations. If we have temporal cases with medically resistant focal epilepsies, then we can proceed with the surgery because we have a neurosurgeon trained in epileptic surgery, this Dr. Wong here. But when we have extratemporal epilepsies that are not feasible to, or we are not able to localize with precision the epileptogenic zone, we have to move to the phase 2, and we work with London as a team. So we present cases to them in a monthly basis to send the patient that we consider require this additional investigation. So they go to London, they have the implantation after a discussion with the London team, and they have the recordings and the final answer in their unit. The long term of our epilepsy program is to move to these phase 2 studies, because Hamilton has a huge population, and hopefully in the middle term.
No, that's fabulous. That's good to hear that we have moved into phase 1 and then moving to phase 2 plan. Fantastic. Thank you for sharing that. I don't see any more questions or comments unless I'm missing. I'm getting used to this system. So if there are no more questions, we're probably going to give people a few minutes back. Dr. Herrera, thank you again for your time today and this overview. And it's pretty fascinating science and helpful for patients with refractory conditions. So I appreciate your time for sharing your expertise with us. And I'm sure people can reach out to you directly if any question arises in their minds later on.
Thank you so much. Just a brief comment for Dr. Amir. In general, any kind of device, it's not going to give you the final diagnosis of epilepsy. Actually, the diagnostic of epilepsy should be done in clinical ground. For example, the sensitivity of the EEG, it's between 25 to 50% of the cases. So if we get a normal EEG, we cannot rule out, and that's a common mistake that we see in, for example, when family doctors are just keeping the patient without a referral to the neurologist because they get normal EEGs in patients having this paroxysmal event. So the semiology, again, is very important, the clinical ground. So there are no devices that are going to replace the diagnosis process other than the clinical information. Then we do some additional investigations for this specific population of drug-resistant epilepsy to figure out if we can offer an additional management.
Yeah, I appreciate that. And we all honestly struggle in the general medicine, and I'm sure family docs the same. Is like, we know that EEGs are not diagnostic. They're actually, if they diagnose, it's good. But they don't, they don't. You just continue with that. That's right. I understand why you've showed us really good videos. Just a question came to my mind is because we do have the epilepsy monitoring unit. There's something that helps in diagnosing these cases as well. I'm sure you attend on that one. Okay.
Right.
Again, I don't see any. If there are no other questions, Dr. Herrera, thank you again. Thank you for your clarifications on the questions, and you have a good rest of your day. And thank you everyone for joining today, and wish you the good rest of your day as well.
Thank you so much. Have a good rest of the day. Bye-bye.